Again, I'd like to thank the conference organizers for the opportunity to speak. This presentation is a little bit different tale of the right place at the right time. I'm not the cause of all these incidents. Please believe me, they haven't followed me to Phoenix. I just, in 16 years working in a level 1 trauma center in Atlanta, we didn't have competition. We're the only level 1 center for a 5 million population for many years. They're just a collection of incidents that allowed us to gain some experience caring for a number of patients. I finished my fellowship June 30th, 1996, and came to work at Emory on the 7th of July. And my two bosses promptly took vacation for the next 3 weeks because the Atlanta Centennial Olympics were going on. They had two new junior partners that they left in control of the hospital. And at about 1:45 the morning of July 27th, I got a phone call from the other guy who started work the same day I did, who said, "A bomb went off at the Georgia Dome, thousands are injured." And that was not quite the phone call I was looking for at 1:45 in the morning. Luckily, it wasn't quite as bad as the initial report was. But again, if you remember this, Robert Rudolph detonated a bomb. He had warned the organizers, and there were about 112 victims, 2 fatalities, one person killed by the bomb itself in close proximity when it detonated, and then one news reporter, a Turkish guy, who was running to cover the story and suffered a massive MI. 111 victims were transported to the hospital. One of the greatest stories of the Atlanta Olympic Park bombing was 111 victims transported to 11 hospitals in 32 minutes after the bombing. 61 of those patients went to a couple other hospitals. Atlanta Medical Center, it's about a mile from us in Atlanta. It's at that time was a level 2 trauma center, now is a level 1. They received about 5 patients, and Piedmont received 4 patients. And of those 9 patients, those are ones they admitted, of those, just a handful of operations were performed. There were 15 minor victims that went to 7 other area hospitals. At Grady, we received 36 people, 35 injured in the blast, and the 1 reporter. And the first patient of all of them to arrive was the reporter with CPR in progress. Following that, 35 people with shrapnel injuries. 19 of those were treated and released, so a little over half. 1 was transferred at patient request after being managed, and 15 were admitted, 10 of whom required surgery, and we got the sickest of the group there. About 3 years later, a guy who was a day trader walked into one financial building up in Buckhead, which is the more ritzy financial district in the city of Atlanta, shot up a bunch of people, walked across the street to another day trading place and shot up another number of people. And in that incident, 21 people were shot. There were 9 dead at the scene, so 12 were transported. 7 came to us, 1 to Atlanta Medical Center, the level 2. And what's interesting here is that 4 patients were transferred to non-trauma hospitals, even though we still had capability to take care of other patients. And all of these individuals survived. Another incident happened in 2007. You may remember this from CNN News or something. There was a team of college baseball players from Bluffton University who were traveling from Ohio to Florida to play games over spring break. And at about 5:30 in the morning, the bus driver mistook an exit ramp for the high occupancy vehicle lane and went barreling up this ramp. And the ramp basically teed into the bridge. It was an exit ramp. And by the time he realized, he hit the brakes, and it was far too late to do anything. He went through the metal fence here, and the bus ended up back on the interstate below. In this, there were 6 fatalities on the scene, the bus driver and his wife and 4 of the baseball players. The rest of the patients, 20 of them came to us, 3 to the level 2 trauma center, and 3 that went to a community hospital. Again, some patients not going to trauma centers when there's still capability. At Grady, we got 2 critical patients. Their injury patterns were almost identical, one with a ruptured spleen, or both with ruptured spleens and traumatic brain injuries, but their outcome was much different. One died at 7 days and one survived to be transferred to rehab despite a severe TBI. One severe grade 4 liver injury who was remarkably stable, and then 17 walking wounded. One young man with a crush injury to his leg was admitted for a couple days. The most recent incident I took care of before I left Atlanta was some of the nice liberal tree huggers in the community at the Atlanta Botanical Garden. I heckle them. I've donated money to this, and it's a beautiful botanical garden. But they got the idea that we spend too much time looking at trees from the ground up and how cool it would be to look at trees from the same vantage point the birds and the bees do. So build this ramp through the treetops to look down at the trees. And as they were pouring concrete, the load shifted and a number of workers fell 30 to 40 feet. There's one fatality at the scene. In this case, all 18 of them came to our trauma center. 3 underwent spinal fixation that day, and 3 others were admitted. Most of their injuries were orthopedic, and all of them recovered. Even those with spinal vertebral injuries walked out of rehab. So my topic is speaking about the lessons that we've learned from these multiple patient incidents. To begin with, pre-planning is absolutely important, and I think most hospitals keep some sort of disaster pack ready. If you have a number of patients rolling in the door that have fake pseudonyms and a medical record number assigned to them, so you don't have to wait for people to be registered. And then even after we went to an electronic medical record, we still used a lot of stickers, which was very great for, rather than having to write down some patient's name, you just grab a sticker, put it on a piece of paper, and you had an instant patient list, and then able to identify the patient. Other aspects of pre-planning that is important. You know, Grady is the public hospital in downtown Atlanta, and like other public hospitals, we suffer from that image. So surely somebody who's an elite athlete involved in the the Atlanta Olympics wouldn't want to seek care at Grady. So Grady was never involved in any of the planning for the Olympic Games. We're going to send the athletes to this hospital if there's a problem. We're going to send the coaching staff to this hospital if there's a problem. There are other support people. They're going to go to this hospital. Nobody ever thought about what to do with trauma patients and include the major level 1 trauma center in the planning. So that was a mistake. Many years ago, my boss had created a fan-out list of all the faculty and fellows and our other subspecialty colleagues who work at the hospital. So it was readily available both in the emergency department and in our offices. So when an incident happened, we had a pre-planned kind of phone tree of who needed to be called. And that allowed us on the big incident to call in people very quickly. On the other incidents, we didn't have to call in additional staff. I will give one plug about how important disaster drills are. And one of the hardest group of people you can get to participate in disaster drills are your physicians. They're above that. First of all, having to take care of patients with fake injuries, and really I've got other things to do and real patients to take care of. But it's profoundly important for the physicians to be involved in this. And again, practice taking care of patients. Do it on multiple shifts, because if you train your disaster on the day shift, then you can guarantee that the bus crash will happen on the night shift when nobody's practiced. So make sure everybody has a chance to participate. And then do it frequently, because like many hospitals, there's staff turnover, and then always debrief. What went right? What went wrong? What do you need to fix for next time? In each of these incidents, we had communication issues, so you can just guarantee that they're going to happen. Our communication with EMS was always suboptimal. As a trauma center, what do we want to know? How many patients are you bringing to us? In every incident, they couldn't tell us. We were getting mixed stories. We'd be told, we got another patient with a back injury who fell at the botanical garden. So you don't know if that's the patient you just heard about or if it's another patient. So there's a lot of surprise. Shows up at the back door. You really don't know. And the EMS responder in the city of Atlanta is Grady EMS, a hospital-based EMS provider. So even though the 911 EMS service in Atlanta is run by our trauma center, we still had communication issues. So the last patient hasn't arrived until the last patient arrives. and never think that the story you're getting is always the truth. Hospital systems can be quickly overwhelmed. You know, everybody who had a family or friend in Atlanta at the Olympic Games, as soon as the bombing went off, all the cell phones were jammed by people using them, so they couldn't get a hold of their loved ones. So everybody was calling the hospital trying to see if their loved ones were there. So that made our phone banks inoperable to communicate with inside the hospital. So have a backup system of walkie-talkies or some other radio system. Triage. One of the mistakes here is, you know, when you have multiple patients, dead is dead, and you don't waste resources on those. And so even though you can kind of understand this guy had a cardiac injury and we're going to try and resuscitate him, with 111 other victims, he was pronounced dead very quickly, unresponsive to ACLS. Retriage. No matter what EMS says their triage level is, we re-triage people at the door because frequently there's over-triage. If EMS sees blood, and I can say that because I'm still a nationally registered paramedic, they see blood, the red ticket goes on. It's immediately tagged, so there's a lot of over-triage. So many of those patients can have a lower level of triage. So post somebody at the door, an emergency physician or a resident who can quickly look at people, do an ATLS primary survey, and categorize them as life-threatening or not life-threatening. Self-triage. In many incidents like this, the closest hospital is often overwhelmed. We didn't really see that at our center because most of these were visitors to the community and didn't know how to get to the hospital. Always be prepared for contamination and set up decon. In several of our cases, the Bluffton bus crash, there was diesel oil, diesel fuel on a number of these kids who had to be cleaned off before they come into the emergency department. And then cement was an issue we had to decon people from with the botanical gardens. In terms of our emergency care, when we have at our trauma center, if something bad is going on, people usually hear about it pretty quickly and self-report to the emergency department. We would just assign physicians, if we thought we were getting a number of patients, just bring down our residents and the staff physicians that were available and just line them up against the wall. And as patients roll in, would assign one doctor or one resident per patient. And you stick with this patient, because if your hospital is anything like ours, everybody groups around the first patient, then the second patient runs in, and everybody moves from the first patient to the second patient, leaving the first person without any help. So we would assign one person per person, and that usually worked very well for us. The lower level residents to the less seriously injured, and the higher level people to the faculty or the senior residents. We would use a lot of manual lists, so even electronic, and this was before Grady got our electronic medical record, but just a sheet of paper with stickers on it allowed us to keep track of patients, what studies they needed to be done, where they were located, and we would meet and update that information. Be prepared for misidentification. The baseball captain was telling me about the two kids who were up in our ICU, both with spleen injuries and brain injuries. And they had arrived before the rest of the baseball team. And from his description, I just didn't think the identification that our hospital had for these two kids was correct. So I actually brought them up to the ICU, and somehow in the initial confusion when they both arrived, their identities were confused. And so clearly, you don't want to be telling the wrong family somebody died. So double check, triple check identity before you release information. Very easily happened. Institutional space, thinking outside the box of places that you can manage patients. When these kids first arrived, they were spread out to open beds throughout all the different areas of our emergency department, which made it very difficult for us to keep track of them. But we had a very large radiology holding area that we then cleared all the patients out of, and then moved all the walking wounded patients into this area, and then brought supplies to the patients. And it allowed us to keep all the kids together, examine them as a group, and proceed with their care in a little bit more orderly fashion. Another thing was that we had all these teenage kids without their parents, and many of them could be discharged from the emergency department, but we didn't want to release them in a foreign city without anybody there to support them. So we had a care initiation on the unit that we were able to move all the patients off of and move all the kids who were stable up to that level and keep them until their parents started arriving from out of town later that evening. So we were able to feed them up there, keep them together, the camaraderie, and they helped each other out. MultiSpecialty Response, never turn away anybody because you never know what injury is going to roll in the door and who you might help. So if somebody wants to be there and you don't need them right away, stage them someplace and let them know you'll call them if and when you need them. Timing and serendipity is a very important thing. With the situation of the 7 shot patients from the Buckhead shooting, it just happened at change of shift. And the off-going day shift OR crew heard about it, stayed. The oncoming crew was there, same for anesthesia. And during the daytime, we still had a number of patients. So as 7 patients rolled in, the first 6 all needed operations. We had ORs, anesthesia, OR personnel to move each patient into an operating room and get them taken care of. I don't know that my current hospital would have the same resources to do that just because it's a smaller place. But many hospitals can accommodate things like that. The leadership teams, frequent meetings every hour, every 2 hours, meeting at the command post, updating leadership. The hospital administration in each of these circumstances was incredible. Anything we needed, they would get for us. So these hungry kids, once they were cleared, they were bringing food up to them. Our chief nursing officer didn't want a leadership role, she wanted a support role. She was down there. If we say we needed 2 more nurses, she found them on the floors and brought them down to the emergency department. So again, having good leadership at your hospital that are team players. Media contacts, if you have to do this, of course HIPAA is an important thing, but you're frequently asked to identify the number of patients. You can't describe identity. But I wish I had kept track of all the interesting questions I've been asked during media interviews. Did you do everything possible? Well, no, not really. You kind of, what they're looking for is that clip that said, we did everything possible. So that's why they're trying to And then in one of our circumstances, we had people coming up with fake ID from the National Enquirer trying to get into our institution to get pictures of a high-profile patient. So always keep your guard up for that. If somebody is around that you don't recognize, have security check them out. Thinking about disposition, where do patients go when they're released, having social services and psychological support. Throughout the day with the Bluffton bus crash, social services reached out to a hotel, or the hotel reached out to us and offered free rooms for anybody who wanted to stay in Atlanta. And so we were able to get folks bused over there. Some weird things that happened. One was during the Bluffton bus crash, one of the kids who was treated at the Level 2 center had just a hand fracture, was splinted, written a prescription. Well, of course, that's what we do and sent out. He ends up back at our trauma center with no money, a hand and a splint, and a prescription. So luckily, our director of pharmacy was there, who immediately took the prescription, filled it, and the kid had pain medication without having to register him at our hospital. So amazing how things can work out. Walking wounded during the botanical garden, somebody was filming it when it fell, and he proceeds to step off the ambulance, walking in our trauma center with a video camera. And we're so dumbfounded by this, it's actually hard to walk up and say, "Sir, what are you doing?" We're just focusing on everybody else. A few final thoughts as I wrap this up. There has to be an incredible relationship between your emergency managers and the trauma program. Because if you have a multiple patient incident, if you have a disaster, injuries are usually going to be a part of it. So working together, pre-planning disaster drills helps that when the real thing happens, you're ready to work together. And the final thing I'll do is give a plug for DMEP. And if you're not familiar with this course, it's the Disaster Management and Emergency Preparedness course done by the American College of Surgeons. It's a one-day course. They invite anybody, they come to a hospital to do this. they allow anybody who might touch the patients to be involved. So you're in a room working through case scenarios with your administrators, your nursing personnel. It's not just a group of doctors doing stuff. It actually allows you to pull your team together who would be involved in caring for patients and think about how you'd handle those scenarios as they come through. Excellent course. Highly recommend it. And then last, a shout out to Tim Berta. This is the kid who was most seriously injured from the Bluffton bus crash. 3 weeks of struggling to control his intracranial pressure. Left going to brain rehab back in Ohio, and has a tremendous sense of humor, is back to doing some athletics, and messaged me on Facebook on a regular basis. So this is why we do it all. Thank you very much.